All right, good morning, everyone. Sorry for the delay here. I'm just had some technical difficulties getting Zoom set up to record. Hope everyone had a good weekend. Good to see everyone back. Yeah, we got an exciting week in class this week. We're going to get to our bone lab this week, continue with our lectures on bones and get into joints a little bit throughout the week as well. So let's just go ahead and jump into it. Today's agenda, I'm going to start off with a quick review of your ticket out from Friday, and then another review activity that, believe it or not, doesn't involve drawing. Then we'll continue our discussion of the appendicular skeleton, getting into the coxal bone or the hip bone. And then I'm going to share with you some fun x-rays just for fun. And then on Friday came up the question of knuckle cracking. I've got a short video that I want to show you about that to kind of illustrate what exactly is happening in your joints when you crack your knuckles. Then we'll continue with the lower limb. And at the end of the class, if we have time, I'll get to a human anatomy in the news that I think you'll find interesting. And then we'll wrap things up with some details on your first exam, which is coming up in the not too distant future, and then some reminders and a quick ticket out. So before we dive in, questions? All right, let's do it then. On Friday, on your way out, I asked you this question: what bones does the humerus directly articulate? You can see the results from the class there. I just want to walk you through and make sure you understand it. So here you see an illustration of a humerus. Is that the right or the left humerus? Right humerus, is it from a posterior or anterior view? Anterior, good. You're looking at the front of someone's arm, so they're in anatomical position, just like this, right? And I asked you, what bones does the humerus directly articulate with? Most of you said the radius, which is correct. Now remember, I really emphasize that your elbow joint is the joint between your ulna and your humerus, but there is a little spot right here where the radius does articulate with the distal end of the humerus. We have this kind of roundish area called the capitulum. The humerus also, of course, articulates with the scapula at the shoulder joint, and that's the proximal articulation of the humerus. And then, of course, at the elbow, the distal articulation with the ulna. And 100% of you got that. So just make sure in questions like this, when I ask you, check all of that apply, that you're answering, that you're checking all of the relevant answers. Yeah. Questions on that? Is that clear? Cool. All right, let's get you thinking about your bones of your hands. Real quick, in your notes, just make a list A to F and identify what bones these are. See if you can do it without consulting your notes, and then we will review it as a class. It's a good check for understanding for yourself. All right, so let's go walk through this. Just make sure you've got a good understanding. To start, what bone is this right here? Radius. How do you know it's the radius? Say again. It's on the thumb side. Good. And also, what can you tell about the shape of that bone? How do you distinguish the radius from this other bone, which is the ulna? So at the wrist, how can you tell those apart? You didn't have any other context. Yes, the distal end of the radius is large, whereas the distal end of the ulna is small. So you know that's the radius, right? And you know that the radius is going to be on the thumb side. And let's take a look at what those answers are. So A is the carpals. These are the bones of the wrist. B is the metacarpals. Those are the bones of the palm. C is the phalanges. Those are the bones of the finger, of course. D and E are the two specific carpals that I wanted you to know, and that is the lunate and the scaphoid. Remember our little mnemonic device that the lunate starts with an L and it's on the side of the wrist with the ulna. The lunate is on the ulna side of the wrist. And finally, we have a special name for the first digit, which is the pollex. And that is the anatomical term for the thumb. Is this a right or left hand, posterior or anterior view? It's a tricky question. Right hand, it is a right hand, yep. Posterior, anterior. Posterior view of the right hand, good. So it's basically this. So I took a diagram and just flipped it upside down. It's a little bit tricky to tell that. One way you can tell it is the kind of shape of the carpals. And you'll see this in more detail in lab. And I won't ask you a question like this. I want you to be able to orient yourself if you're given a diagram to know if it's right or left, anterior or posterior. But I'm not going to ask you to distinguish that based on the shape. That's one way you can tell. When you have, I don't have a slide handy, but when you have an anterior view, when you're looking at these carpals, you'll see a different aspect of them, and they have different shapes. You can see, for example, the capitate is this kind of long rectangle from one side, but more of a square shape from the other side, for example. Cool. We also have a knot on these diagrams, but I want to ask you this question anyway. There are some tiny little bones right here in this joint between the first metacarpal and the first phalanx of the proximal phalanx of the first digit. There's some little bones right in here that aren't shown. What are those bones called? Sesamoid bones. Good. And those are special bones because they develop kind of embedded in the ligaments that attach the bones. We talked about the patella that we'll get to later today in more detail, but the patella being a prime example of that. Any questions on that? All right, jogging your memory. Let's get back into the appendicular skeleton. And we left off talking about your pelvic girdle. This, of course, is the attachment point between your lower limbs and your axial skeleton. This slide I showed you already. I'll just quickly review it to refresh your memory. You have three bones of the pelvic girdle, left coxal bone, a right coxal bone, and the sacrum. Together, they form this continuous circle of bones that forms this girdle. Now, the girdle is important because it's supporting a lot of weight of the body, distributing that weight to the limbs, and also well, I guess that's two of the things I want to mention. It's important because it's supporting this weight, and it's also the attachment point to the limbs. The femur, which is the largest bone in your body, articulates with your coxal bones at this cup-like structure called the acetabulum. And that's this really deep kind of bowl-shaped structure here that allows the head of the femur to articulate very stably with this joint. Now remember, the acetabulum is homologous, or that's not the word I want to use, analogous to what structure on your scapula? Glenoid cavity, yep. And the main difference here, well, important difference, is that the glenoid cavity is kind of shallow. Again, I know I've said this a bunch, I'll repeat it one more time. That allows for great range of motion of your shoulder at the expense of stability. Whereas in your leg, you have more limited range of motion. Well, you still have a pretty darn good range of motion at your hip joint, but it's a much more stable joint simply because it's much more load bearing. So let's look at these coxal bones in a little more detail. The term coxal bone is synonymous with hip bones. I generally like the term coxal bones more in this case, simply because when people talk about your hips in vernacular, they're not really talking about the bone. They're kind of talking about this whole structure. If we want to get really technical, we can refer to these in the Latin term as os coxae. What's cool about this bone is that it's actually formed from three bones. So when you are young, when you're born, these three bones are separate. A bone called the ilium, a bone called the ischium, and a bone called the pubis. Now, throughout your early life, these three bones fuse together to form one bone. They don't completely fuse until you're around somewhere in your early 20s generally. And so the stability of this bone increases as you age into young adulthood. What's important to note here, a couple things, is that even as this bone is one continuous bone, referred to as the coxal bone, we still have three kind of regions of the bone that we refer to by the same name as these three bones that fuse together, the ilium, the ischium, and the pubis. So you will want to know those terms. Also note that the acetabulum, this cup here where the femur articulates, is actually the meeting point of those three bones. So you've got the acetabulum is formed by parts of the ilium, part of the ischium, and part of the pubis there. So looking at this bone, is this a right or a left coxal bone? It is the right, and is which side is anterior, which side is posterior? Which way is this facing? Is this anterior or posterior? Anterior, good. So this is a right coxal bone anterior, so this is someone standing like this. The right coxal bone with this way forward. Abby, go ahead.
Are there like developmental disorders where the bones don't necessarily fuse together?
That's a great question. Are there developmental disorders where the bones don't fuse together? I don't know of any off the top of my head, but I'd be surprised if there weren't in some way. That would affect your joint motion for sure, but I'm not 100% sure what that would be called or what the result would be. I'm sure it would result in lack of stability in that hip joint. Go ahead, Gia. Well, so there is especially early in development. I mean, as you're like learning to walk, so between 6 months and 2 years, these bones change dramatically in response to you changing the way you carry your weight. In terms of does our gait change, let's say from the time we're, 10 years old, where we're walking a ton, to mid-20s when these bones are fully fused, I don't think it changes because they're attached with this kind of, they're strongly attached with cartilage. It's not like there's a lot of flexibility by the time you get to that point. But you can see, actually, I show you here, early in life, I don't actually know what age this was, but you can see in an x-ray here, the cartilage doesn't show up. So I don't want you to get the impression that this is like broken or there's big gaps here. Remember, these empty spaces are filled with cartilage that's binding it together. You just see it in x-ray, but you can see very clearly here, these three bones fusing together to form a coxal bone. So what I want to do here is just kind of break down each of those three parts of the coxal bone and identify some features. You'll look at this in detail in lab as well. So just as a reminder, we'll talk about things on the slides here, but we have lots of coxal bones in the lab. You'll be holding them and looking at them from all different perspectives, which again, I think is a better way to learn some of these features. So the ilium, I want to talk about first. That's the most superior region of your coxal bone, and it's this big kind of flat, almost like a wing, which is why it's called ala. So ala comes from the Latin or Greek word for wing, and it forms the whole upper part, the whole superior part of the coxal bone. The two primary parts of your ilium are the ala, which is this big flat wing-like structure, and then the body, which is this kind of thicker part, more inferior. Lots and lots of leg muscles attached to the ilium of your coxal bone, and we'll talk about those when we get to muscles in a little more detail. And it articulates importantly with the sacrum to form the sacroiliac joint. I should have this one highlighted in red. I want you to know that. And that joint is actually going to be right here. Now, it doesn't look much like a joint in the sense that we think of a joint in terms of something like your elbow or your knee, right? But this is where this bone articulates with the sacrum, and it articulates very tightly. It's bound together tightly by ligaments, so there's not a lot of flexibility there between the coxal bones and the sacrum. So is this a right or a left coxal bone? It's right, good. And which direction is this? Posterior, yep. So again, this is a right coxal bone. Looking at it like this, you'd be looking, rather than removing my left coxal bone, looking at the right coxal bone here, and this part right here. Next, we have the ischium. This is the kind of posterior and inferior aspect of the coxal bone. And there's two parts of this I want you to know. The body, again, the same term we use for this part of the ilium, used for this part of the ischium, it's the bigger, thicker part. It's hard to see that it's thicker from this perspective, but when you get these bones in hand in the lab. And then we have what's called here the ramus. Ramus comes from the word for arm. So we have this kind of arm-like structure that forms this little circle, I'll call it, with the pubic bone. I'll talk about that more in a second. There's one important feature on here I want to make sure you know, and that is something called the ischial tuberosity. Fun to say. This is the thing that right now is supporting most of your weight. This is where all your weight goes when you sit. So if you want to now or later when you're sitting by yourself, if you put your hand under your bum where you're sitting and you feel like the hard bony part that's bearing most of your weight, that, my friends, is your ischial tuberosity. So that is where your weight is born when you're in the sitting position. And also there's lots of muscles that have their origin there as well. So specifically the hamstrings. We haven't gotten to this yet, but the hamstrings, probably know this, they're the muscles in the posterior of your upper limb, or the muscles in the posterior region of the proximal aspect of your leg. So basically those muscles behind your thigh. And they have their attachments here. And you can feel that bone very prominently when you're sitting. You can try that later on by yourself, so no one thinks you're really weird. I'm going to walk through a little bit of it more on the ischium. Just want to show you this diagram. You don't have to worry about the details of these muscles yet. We're going to get into all that when we talk about muscles. I just want you to see how these muscles attach to that ischial tuberosity. And then you can see here, actually, no, that's all I want to show you on that. And these aren't, this diagram just kind of shows you where those muscles are. This isn't what they actually look like, but it serves to show that attachment. One more part of the coxal bone is the pubis. The pubis is going to be the anterior and inferior aspect of the coxal bone. In the anatomical position, it lies more or less horizontally. So let me just flip ahead one slide, then I'll flip back. I just want to show you what I mean by that. Notice that the pubis, which is like this region right here, is horizontal when you're in the anatomical position. In fact, sometimes we think of this pelvic girdle as being something that's like shaped like this with the opening in the middle, but in fact, this opening is more or less facing forward when you're standing in the anatomical position. So importantly, one feature of the pubis that I want you to know is this pubic symphysis and what's called the symphysial surface. This is where the two coxal bones meet anteriorly. And again, remember, this is that really strong type of cartilage called fibrocartilage that we find here in the menisci of your knees, and around the annulus pulposus of the intervertebral discs as well. And this is also, we have a number of attachments for muscles that adduct your thigh as well here. So adduct means we haven't talked about this yet, but it's when you move your limbs in towards your body. So it's attachment points for limbs that are going to move your leg in towards, move your leg medially towards the center line. One last thing I want to point out is that the pubis has these rami as well. Rami is the plural of ramus. There's a superior and inferior, and these together with the ramus of the ischium form this structure right here, this kind of ring-like structure. Yeah, please. That's correct. There's no other bone there. It's just the joint between the two, the anterior aspect of the two coxal bones. And actually, let me just show you that. It's this guy right here. Does that answer your question, Gia? Kind of?
Yeah.
Okay. The pubic joint or something? Yeah. Yeah. I gotcha. The word symphysis really generally refers to when you have a joint that's really tight and there's not a lot of movement, right? And so you have this symphysis here between the two what's the plural of pubis? The pubis of each your left and right console. So this is an anterior view of the entire pelvic girdle. You can see here, I want to show you is that we have the rami of the pubis and the ramus of the ischium form this circle. And this circle is called the obturator foramen. Foramen simply means hole, and obturator is the name for that. I don't actually know what the root of that word is. So that loop, that passageway there is the obturator foramen. And again, we'll see this in lab. Yes, please, Abby.
Can you explain the whole horizontal?
This here?
Yeah.
Yeah, so often people think of the structure, if you give someone a whole, like a set of bones, that's the pelvic girdle, and you say orient this as it is in the human body, people are often tempted to orient it. I'm going to do this in front of the camera here. They're tempted to orient it kind of like this, as if it's like a circle with the hole facing up and down, when in reality, it's actually oriented more like this, where that hole, I'm not using good anatomical terminology here, but the hole is oriented so that something could pass through it more front to back. I mean, there is a slight angle, but it's more front to back than up and down. Mm-hmm. So this is, in other words, this is an anterior view in the anatomical position. Notice you can see right through this hole. This hole, that's a terrible way to say it, but just for example. One other feature I want to point out here is this structure called the pubic arch. This is essentially this angle formed by the anterior aspects of the two pubic bones that come together here. And that pubic arch is one of the distinguishing characters between female typical and male typical pelvis. Pelvis is the plural of pelvis. And so you can see examples here where I'm not going to have you answer this question. This is a female typical pelvis. This is a male typical. And you can see the male typical pelvis is a bit taller and skinnier compared to the female typical, which is generally a bit wider. And the pubic arch, especially in female, is much kind of broader. It's a much greater angle here than the male, where it's a much tighter angle. And this generally has to do with an adaptation for childbirth. So when a baby is born, it passes through here, generally head first. And in females, who are going to give birth to children, or say that, how do I want to say that? In anatomical females, where there's the potential to give birth to children, it's advantageous to have a wider passageway there for a baby to pass through compared to a male's, where you don't have that. And we have something called the pelvic inlet, which describes like the width of that. Well, we have the pelvic inlet, and then we have don't worry about that terminology. I'm not going to go into that whole detail, but basically, the pelvic inlet describes the diameter of that opening there. And you'll see we'll actually do an activity in lab where we have a bunch of pelvises around the lab, and you find those and you try to identify if they're male typical or female typical. Notice that I'm using the terms male typical, female typical. You can't tell if you're given a pelvis, you can't tell like with 100% certainty if it's male or female. There's lots of variation. So I just want to make it clear that there's lots of variation amongst everybody, all humans, in the size and shape of these bones. Certain bones have more patterns that are generally more characteristic of anatomical female versus anatomical male. So we want to talk about it in those terms, but I just want to make sure we're clear that there's tons and tons of variation in that as well. So one thing that did come up in class last time was this idea of what's called pubic symphysis diastasis. This is when this pubic symphysis becomes damaged and that articulation is no longer present. And so this would be like a normal healthy pelvis, and then we get something called this diastasis, where those bones can actually break apart. Now, it doesn't necessarily, this is pretty dramatic. It can be dramatic, but it can also just be like a stretching or a partial tear or something like that. But it can be up to 10 millimeters, which is what, about 4 centimeters or 4 inches or so. Is that right? Yeah, about 4 inches or so, which is, that's a sizable gap. And it can happen due to the pressure of a baby's head passing through that pelvic inlet, right? It's not common, but it obviously can be pretty debilitating. And so what happens is that basically this cartilaginous joint just gets stretched beyond its capacity. Yeah, there's a little more detail than we need to worry about. The numbers here is that there's the complete separation of the pubic symphysis is about somewhere between 1 in 300 and 1 in 30,000, which is a huge gap in diagnosis, simply because there's not necessarily great data on it. In many cases, it goes undiagnosed. If someone's suffering from a lot of pain after childbirth, it's not necessarily clear that this could be the cause of it. There could be other things that happen as well. So yeah, I just want to present a bit of information because you did ask about it. Gia, go ahead. It's funny. I was just thinking to myself that someone had asked that last class, and I don't have a good answer for that right now. It's going to depend for sure on the severity. And so if it's completely detached, it would probably, I'm going to guess it requires some kind of intervention, but let me look that up and get back to you. I'm not sure how they help prepare that. But what's important to think about is how this would impact a person mechanistically. And specifically, I mean, here, if your femur and all of your weight of your body is transmitted from the coxal bone to your femur here, if this joint becomes unstable, right, then for example, walking is going to put pressure on this. It's going to further pull it apart. It's going to be really painful. You're going to be really unstable, probably immobile in severe cases as well. And that's all I'm going to say about the pelvic girdle. I'm going to take a quick diversion here and show you some x-rays in a video before we get into the lower limb bones. But let me pause, see what questions you have. Make sure you're up on the notes. All right, just as a fun aside, I wanted to share some x-rays. Holly was kind enough to share her broken finger x-rays. And so this is the distal phalanx of her third digit, right? Your middle finger. And she broke the bone last week. And here's an x-ray of her hand. You can see, I actually can't see very well here. But you can see kind of right in here, let me just show you. You can see like this line right here. It looks to me, now I'm not saying this 100% for sure. Did they tell you there's 1 or 2 fractures in there?
They said that it was just the one that's coming from the top of the bone. Yeah,
like right down here. Yeah, you can see this line right here. You can see the little tip of this this bone kind of being just you can see the line there where it's removed from the rest of the bone. So I just wanted to show you that it's an illustration. It's kind of perfect timing that you broke your finger in class. So thank you, Holly, for doing that. Appreciate that. And also, since we're talking about the coxal bones, here is a set of coxal bones where the hips have been replaced. You can see what they do here is when they do what's called a hip replacement. Basically, it's due to severe osteoarthritis in this joint. So all the cartilage that's normally here that facilitates the movement of the head of the femur in the acetabulum of the coxal bone wears away, and it can be really painful. You can develop bone spurs, et cetera, et cetera. And what they do is they lob off the top of your femur. They drill out the acetabulum. They put this ceramic and plastic cup in there, and then they put this prosthesis in the head of the femur. And what they do is they actually hammer this thing down into the bone. And this thing you can't see in the x-ray, but it's kind of porous, like it has a rough surface, so that when the bone regenerates, it actually regenerates around that. So there's no glue or anything here, but the bone itself holds the prosthesis in place. So this is actually in recent years become very common kind of surgery. But you can see that minor, what I've been told is that it's really more of a construction process than an operation. They're literally using saws and hammers and like drills to grind out this acetabular. You can see this the size of the screws in here as well. It's pretty dramatic. And just for the record, this is my x-ray. This is my hips. I had both of them replaced in the past year and a half or so. No, I had one in like a year and a half ago and one last November. So yeah, good times there. I see lots of hands. Let me get Kylie first, or excuse me, Taryn first, and we'll go around.
Is a hip replacement similar to a knee replacement in a way that like usually you have to do it again?
It can be. So the life of one of these prostheses can be, I think it's in the age of around 20, 25 years. So normally, most often this kind of surgery happens with older folks where that's going to last them through the rest of their lifetime. In my case, I'm hoping that I have another at least 20 years left in me. And so chances are that I'll need this replaced at some point. And apparently the second one is much worse than the first because they have to like rip all this stuff out and then put new stuff in. And so I need to be careful. Like, so I can't go run. I used to run a lot, and I can't really run on pavement anymore. I can, but it'd wear this down faster, and then I'd have to get the second one replaced. No, I bike more than I used to. Yeah. I saw another hand. I think Holly, you had one, or no? Zoe, go ahead. Yeah. It's continuous. They say it takes basically a year to be completely healed. What's crazy is they have you standing and even taking some steps the day of the operation or the next day, because the way that it's structured, you're not going to pull all the weight kind of pushes basically helps push everything together as you put weight on it, very gingerly and very slow, but they want you up moving around like really pretty fast. But yeah, it takes a long time. Having said that, again, this comes up again and again in class, that bone really heals well and is really this kind of dynamic tissue that can regenerate, has amazing capacity for regeneration. I think Julie, you had, yeah.
Because I heard somewhere that you can dog. Doesn't have to be synthetic.
I don't know of any cases where you could replace it with like living tissue from another person or from an animal or something like that. Not in this case with bone, especially the way that it's kind of hammered down into here. So I think in this case it's synthetic, and it's titanium and ceramic and plastic. So it's neat. It's amazing though. I'll say that like I would much rather have had this done than like knee replacement surgery is much more takes a lot longer to heal and is much more uncertain because that joint is so much more complex. The hip is actually a really simple joint. It's just a ball and socket joint, and actually the recovery from it is remarkably quick compared to a lot of other joint replacements. Go ahead, Raj. I don't know. What's amazing to me now is like I can do everything. Like I've gone surfing, I've gone skiing. I have to take it a little bit easy, but I'm not really adventure guy anyway. The only thing I need to be careful of is not to do things where I'm going to wear it down, like running on, like I can't go jogging anymore, which is a bummer, but that's pretty much the only thing. So, and it's amazing. I'll tell you for a better part of a year, going on 2 years, like every time I took a step, I was in pain. The joint was just like a mess, and now it's like great. I don't even think about it. I'd rather not have had it done when I'm, in my early 40s, but there you go. So one more hand. Yes. Yeah. Yeah, that's it. Yeah. I mean, everything else I can do. I disappointed that it doesn't set off metal detectors as much as I had hoped, but every once in a while it will buzz and I have to explain it. When they get the wand and they pat it down.
It's just like a fun story. My mom had her knee replaced, and she went to Mexico with my older sister. Coming back into the country, she like forgot to tell them that like she had a knee replacement. Went through the metal detectors and like set everything off, and like they didn't believe that she had a knee replacement, so like she had to have like a full like pat down and like go through all of that stuff. And
yeah. Well, it's funny though, because I asked about when I got this, is there like, I don't know, a card that I need to carry that says like part of my body's metal? And they're like, no, because then people would just get fake ones of those and, then be like, oh yeah, my leg is metal and, carry whatever they want. So basically you just have to tell them and then they do like the Julia.
But it's kind of weird because my mom had like thyroid cancer
Mhm.
and she went through the treatment and all that. And because of the treatment, every time she goes to like the airport security, it goes up like
Yeah.
in her neck. It shows like she has something in her neck.
Okay.
It's because of the treatment.
Yeah.
There's no.
That's really interesting. I
Yeah.
wonder if it's some of the tracers that they put in there. Huh.
But it's so weird.
Yeah. Yeah. It's just I don't know, just makes it that much more complicated sometimes.
It actually works very well. It's crazy to see like different joints go up and other ones just
Mhm.
like brand new.
Mhm. Yeah, I can imagine too. A lot of it depends where the joint is. So like, this joint is in the hips, but there's a lot of like flesh and muscle around it. So it's kind of deep relative to, say having like an elbow, like a metal plate in your elbow where that's just exposed right there. Cool. Let's talk about knuckle cracking. So I have this as a QR code. You in class don't need to worry about this. I'm putting this up for anyone watching the video because I'm going to pause the recording while I show the video here because it's weird to record a video. Also, I think it infringes on copyright. So if you're watching this video, go ahead and scan this QR code and you can watch the video. Those of you here, I'm just going to pause the recording for a second. All right. So given the time, we're not going to get into any more of the lower limb. And I'm actually going to skip our human anatomy in the news for today too, or get to that. Oh, guess we're not doing anything. Oh, no, there we go. Worked. Come on, computer. Yeah. We'll get to the human anatomy in the news on Wednesday. So you'll see a link to human anatomy in the news, the article in your program for Wednesday. You can ignore it. I'll put it in again for Friday after we talk about it. You can see we're going to get into joints and all kinds of good stuff later in the week. This will take us through the end of the week. But I want to wrap up with a ticket out and some details about lecture exam number 1. As you saw, it's on the syllabus scheduled for next week. And in fact, it will be next week, a week from today. So that's Monday, the 26th of September. It's going to be online in Blackboard, open all day. We will not meet for class that day. So you can schedule it. Is that bad or good? It's good. Okay. I thought that was a pain look. Like I'm going to miss class on Monday morning. So instead of class, you'll take your exam on your own time. It's going to cover everything we've done so far in class in lecture. So not lab, just lecture material through what we cover Wednesday this week. Through our next lecture. It'll be multiple choice questions, drawing questions, labeling, short answer. So kind of mix of everything. Open book and open note, but you've got to work by yourself. So please don't share information with each other. My intention is to create an exam that would take an average student just under 50 minutes to take. So it's the length of like one class period. But in Blackboard, I'll set it up so that you have 70 minutes to complete it. So I'm hopeful that you won't be rushed. Those of you with time accommodations, those are automatically set in Blackboard as well. So for example, if you have a 50% time accommodation, then you will have 105 minutes to complete this in Blackboard. It's worth 100 class points, so it's worth a lot. And in your class program for Wednesday, I included a bunch of study tips. So check those out in your class program for Wednesday. And as a final reminder, it is open book and open note, but please stick with material that you've learned in class. So class notes, any videos assigned, any readings assigned. Please don't just do Google searches for the answer because it will only serve to confuse you and probably me while I'm grading it. Any questions on that? Okay, cool. I have a ticket out for you today and a reminder that I have open hours from noon to 2 o'clock today in the lab room. Remember, I don't have a bit for this, but remember you have a lab quiz tomorrow on your histology slide. So this would be a great time to come in, check for understanding on those. And also Danny has tutoring sessions, again, Monday evenings in the lab room. So that's a great time to come in as well. Check out those slides and make sure you have good understanding. That's all I've got. Once you finish the ticket out, we're good. I'll be happy to answer any other questions.